Welcome to this session of Understanding Human Anatomy. In this session, which is a continuation of the upper extremity, I want to talk about a retinaculum. The plural of retinaculum is retinacula, so I'm really going to be talking about retinacula. And it's important to understand why these structures exist and the importance of the structures. So I'm going to start with a very crude diagram. You can see here that is a schematic of 3 bones. And what I want you to consider is a muscle that's going to act to flex these bones running up like so. And draw the muscle in down here. Okay, and I'll fill that in to make the muscle more visible. So this is a structure, at least schematically, that we see a lot in anatomy. A muscle with a tendon that stretches across another bone to insert on a distal bone. Now let's look at what happens when this muscle contracts. The diagram on the left is the one from the last slide. On the right side, I've shown the bones in the position after this muscle is contracted. So let me sketch in the muscle again. And here's its tendon coming up to the distal bone. And again, I'll color in the muscle. You see that the tendon, and to a certain extent the muscle, is pulled away from the bones. So it resembles the string of an archery bow. And this is a situation called bowstringing. So that the tendon pulls away from the middle bone and we get this gap. And number one, that becomes a problem because the skin would have to stretch along that gap and then it would get flabby when the bones were back in this original position. And it also lessens the efficiency of this muscle. This muscle is trying to flex this joint, this distal joint, not both joints. And so when it pulls, you don't get a full flexion and you lose efficiency. Next, let's put a retinaculum into the diagram. Now, on the right, we have the original schematic diagram of the bones that we started with. And let me draw in the muscle attaching to the proximal bone, and then having tendon run past the middle bone up to the distal bone. Okay? But in this diagram, I'm going to draw in a retinaculum. And I'm going to do that in blue. And I'm going to do this here in the area of the middle bone. So, and I'm exaggerating the spaces involved here, but just give you the idea that the retinaculum surrounds the tendon and ties it to this middle bone. Now, it doesn't attach to the tendon. The tendon is free to move within the retinaculum. So that here is our retinaculum. So the retinaculum's in blue. And as I said, the tendon can move within the retinaculum, but it keeps the tendon close to the bone. So in the next slide, we'll show what it looks like when this muscle acts and the retinaculum is there to prevent the bowstring. Now, on the far right, we have these schematic bones, how they will look when this muscle contracts with a retinaculum. So let me draw in the muscle again. Color in the muscle. And then sketch in the retinaculum again. So you can see the retinaculum prevents the tendon from pulling away from that middle bone and bowstringing. And you also see that the amount of flexion at that distal joint is increased because the muscle is much more effective with a retinaculum. So that explains what a retinaculum is and how it functions. I want you to take a look at two retinacula in the upper extremity in the region of the wrist. And in essence, there's a retinaculum on the flexor side and a retinaculum on the extensor side of the wrist. So we'll look at the flexor side in the next slide. Now this slide shows an anterior view of the distal end of the radius and ulna, the carpal bones, and the metacarpal bones. And I've sketched in flexor tendons. These would be the tendons of flexor digitorum profundus and flexor digitorum superficialis, kind of combined together. There are other tendons that would be in this area as well, but that would just complicate the drawing. You see these tendons run from the forearm, from the anterior compartment of the forearm, down through the wrist, across the metacarpals. Eventually they insert onto the phalanges. Profundus, flexor digitorum profundus inserts on the distal phalange. flexor digitorum superficialis, the proximal phalange, and I also have in there the flexor pollicis longus. Now, I'm going to sketch in the retinaculum, which is also called the transcarpal ligament. And it will start here on the side, come up to the radius, over to the ulna, back on the other side, and then across. This is the transcarpal ligament. And it's kind of hard to see like that, so let me color it in. Like so. And then, just to give it some definition, I'll draw some lines across it to indicate this is made up of connective tissue. So, this is a structure that is called the transcarpal ligament. And that transcarpal ligament forms the flexor retinaculum. And this retinaculum holds all these flexor tendons onto the wrist, onto the carpal bones, so that you don't have bowstringing of the long flexor muscles going into the hand. Now, what this does is create a tunnel, and this tunnel is called the carpal tunnel. And not only do the tendons pass through this tunnel, but arteries, veins, and nerves pass through this tunnel as well. And this becomes significant when you get an inflammation in the tunnel. And whenever you have inflammation, you get swelling. The swelling puts pressure on the nerves and causes pain. It can also cause the nerves to trigger, and some of the muscles will sometimes contract and not relax. this is carpal tunnel syndrome. It's most commonly caused by overuse of these long flexors. And this happens when you are typing or keyboarding, using a mouse. And it's become quite a problem in modern day with the advent of computers. So, carpal tunnel syndrome is caused by an inflammation in the area deep to the transcarpal ligament, deep to the flexor retinaculum. Now, there's a retinaculum on the extensor side as well, and we'll look at that in the next slide. On this slide, what I've done is pronate the hand, turn it 180 degrees. So we're still looking at a diagram of the right hand and wrist, but now laterals on the left side instead of the right side. When you're trying to tell the difference between medial and lateral, the head of the ulna is always going to be the medial side, and the styloid process of the radius is always going to be the lateral side. And the distal ends, the ulna and radius, are significantly different, that it makes it fairly easy to tell medial from lateral. So this would be the first digit, the thumb. Now, there's a retinaculum on this side as well, which I'm going to draw in here. And again, I'll color it in to make it more visible. And like I did for the flexor retinaculum, I'm going to draw in some lines, some fine lines, just to remind you that this is made up of connective tissue proper, with fibers running through it, and the fibers would be oriented in the way I'm drawing the lines, transversely across this retinaculum. And this is the extensor retinaculum. The extensor retinaculum. Now, the extensor retinaculum is divided into 6 compartments. Six compartments or 6 tunnels. And what I'm going to do, just to indicate these compartments is just draw a line. I'll make it a little more prominent. Just draw a line through the compartments or around the retinaculum to indicate the compartments where their approximate location. So if you look, there's 1, 2, 3, 4, 5, 6. Partially this is just because there's a lot less space on the dorsal side. On the palmar side there's much more space, and so that there's less opportunity on the palmar side, the flexor side, of having the retinaculum attached to bones midway across. So this is the extensor retinaculum. That concludes our discussion of the retinacula, at least of the upper extremity. But in the next video, I'd like to discuss two structures that are associated with retinacula and with muscles, and these are tendon sheaths and bursae, and they help cushion the movement of tendons across tendons, tendons across bones, and muscle across bone. Thank you for your attention.